All right, let's trace the entire biological journey of breast cancer. In this step-by-step explainer, we're going to follow the path from the very first risk factors that put pressure on a normal cell all the way to a full-blown invasive disease. Understanding this pathway is absolutely key to figuring out why screening works and how modern treatments are designed.
So, how does this actually happen? How does one healthy cell start going rogue? Well, it's not a single event, not like flipping a switch. It's more like a domino effect, a biological cascade where each little step triggers the next, slowly, over time, transforming a normal cell into something really dangerous.
In that journey, it doesn't just start in a vacuum. It begins with a combination of pressures, all acting on normal breast cells over a very long time. We can really boil these pressures down to three main drivers.
Okay, so these three things, they work together for decades, especially after menopause. Just imagine it. You've got years and years of hormonal exposure from estrogen, which is basically a constant go signal, pushing cells to divide over and over. You combine that with environmental influences, and what you get is the perfect storm for genetic errors, little typos in the cell's DNA, to just pile up.
Now, what's really interesting here is how this slide breaks down the two main ways a cell's instruction manual can get corrupted. Most of the time, the damage is acquired. It happens bit by bit, over a lifetime, right there in the breast cells themselves. But in a smaller number of cases, a person actually inherits a faulty gene right from the start.
So here's a perfect example of that acquired damage. About 30% of invasive cancers have something called HER2/NEW gene amplification. Now, HER2 is a protein that helps control cell growth. When this gene gets amplified, it's literally like a car's accelerator getting stuck to the floor. It causes relentless, aggressive cell growth, and unfortunately, it points to a worse prognosis. On the flip side, you have inherited mutations like BRCA1 and BRCA2. These are a totally different kind of problem. If HER2 is a stuck accelerator, think of a BRCA mutation as a faulty DNA repair crew. The cell's built-in ability to fix those genetic typos is busted from day one, which is why these mutations often lead to cancer at a much younger age and are linked to a really strong family history.
So here's the crucial point. All this genetic damage that's been building up, it doesn't immediately create a widespread crisis. The very first major development is a contained, pre-invasive problem that we call carcinoma in situ.
This concept is absolutely critical. In situ literally means in its original place. The cancer cells are there, and yes, they are malignant, but they're trapped. They haven't broken through this natural boundary, this basement membrane that separates them from all the surrounding breast tissue. This whole process gets started in the terminal duct lobular units, which are basically the milk-producing parts of the breast. You could call it the factory floor.
Okay, so let's see how this actually plays out. There are two main types of this in situ carcinoma: ductal, or DCIS, and lobular, or LCIS. As you can see, they look and behave very differently. But the most important difference, the real so what here, is that key feature. DCIS often calcifies, while LCIS almost never does. And that single biological difference, well, it has massive implications for how they're found.
When a pathologist looks at DCIS under the microscope, they see all these different architectural patterns. But the one we really need to focus on is the Komodo type, or Komodo carcinoma, because it's the most aggressive, high-grade form, and it has a very telling characteristic. And this, right here, this is the aha moment of modern breast cancer screening. In high-grade Komodo DCIS, the cancer cells grow so incredibly fast that the cells in the center of the duct actually die off, creating this necrotic debris. And what does that debris do? It calcifies. A mammogram is just an X-ray, and it can see these tiny bright white specks of calcium long before anyone could ever feel a lump. It's amazing. Now, in some pretty rare cases, DCIS makes itself known in a very visible way. The malignant cells can literally travel up the duct system all the way to the nipple surface, creating a skin lesion. This is called Paget disease, and it's a clear external sign that there is an underlying carcinoma deeper inside the breast.
LCIS, on the other hand, is almost always completely silent. And because it doesn't calcify, you're just not going to see it on a mammogram. It's usually just an accidental finding when a biopsy is done for some other reason. Its main importance is that it acts as a marker, a signal of an increased risk of developing invasive cancer in both breasts down the line.
So now we have this contained problem, right? Either the DCIS that can sometimes be seen or the silent LCIS. But the story doesn't stop there. The climax of this whole cellular journey is the breakout, that transition to invasive cancer.
This is the moment everything changes. The malignant cells are not contained anymore. They've broken through that basement membrane security fence and have invaded the surrounding tissue, the stroma. And once they do this, they gain access to the body's highways, the blood vessels and the lymphatic channels, giving them the potential to spread.
So pathologists will grade this invasion based on how much the cancer cells still look like normal, well-behaved breast tissue. Well-differentiated tumors are still trying to form normal structures, like little tubules. But the poorly differentiated tumors, they're chaotic. They form these irregular sheets of cells that look nothing like where they came from. And the rule is simple. The less they look like normal cells, the more aggressive they are.
But just grading the cancer's appearance under a microscope, that's not enough anymore. In the modern era, we also have to understand its molecular identity, because this is what truly dictates its behavior and, most importantly, how we treat it.
This simple table is incredibly powerful. It classifies tumors based on two key things: the estrogen receptor, or ER, which acts like a fuel source, and the HER2 receptor, that stuck accelerator we talked about. This creates 4 distinct groups, and they all have different treatments. So luminal A tumors are fueled by estrogen and respond really well to hormonal therapy. Luminal B is also fueled by estrogen, but it also has that HER2 accelerator, so it needs a combo of therapies. HER2-positive tumors are driven by that accelerator and are treated with targeted HER2 drugs. And then you have basal-like tumors, or triple-negative, which lack all of these targets, making them the most challenging to treat.
Okay, so let's tie this entire cascade together. Let's connect every single biological step we've just walked through to really understand why this whole journey matters so much for patients.
This is it. This is the whole story, all in one logical sequence. From the very first environmental or hormonal push, all the way to the final outcome and its treatment.
So the crucial takeaway is this: estrogen drives proliferation. A faulty BRCA gene means the cell fails to repair DNA damage. HER2 accelerates growth. DCIS calcifies, which is how we find it early. LCIS is silent, but it warns of future risk. An invasion happens when the cancer crosses the line of the basement membrane. Every single biological fact has a direct clinical consequence, and it just perfectly illustrates that in medicine, understanding the fundamental why of a disease is the only way you can ever truly understand the what.